to Ashraf for the introduction, and I would like also to take this opportunity to thank the Saudi Urological Association for the invitation of Dr. Raif and his colleagues. Today, in the coming 30 minutes, I would like to share with you an interesting debate when it comes to the medical management of PPH. And the title is 5 alpha reductase inhibitors and alpha blockers in the PPH patients. The debate is whether to start early or late. My name is Wael, and I'm a physician by education, and I'm working as head of urology section in GCC. And although I'm paid by GSK, I'll do my best today to be as neutral as I can. All the slides are referenced. As you know, prevalence of the hyperplasia, enlargement, and lots are increasing with age. If you can see here, if we take the sixth decade, we can see that out of 100 patients or 100 population, 70% would have hyperplasia. 50% of them would have enlargement, and another 50 with LUTS. And if taken into consideration patients who are presented by LUTS and enlargement, it represents like 1/3 of the patient at the age of 60. And you can see how common is this. The second thing also, it is a progressive disease. We came to know from the first landmark study, the MTOPS study, especially the placebo arm, those patients who were enrolled in the study for more than 5 years. And you can see here, 17% were clinically progressed, 14% only symptomatic progressed, and 6% would have surgery, 2% had EUR. The first question is, can we predict who will progress to EUR and surgery? The answer is yes, you know. New patients can be progressed for EUR or surgery, depends on mainly 5 attributes. The first one is age. It is an aging disease. So the older the patients, the more likelihood of EUR. So if we take like 50s, the likelihood of those PPH patients in the 50s is 3.2 percentage, increasing, doubling or more if they are 60s and so on. Not only age, but again, the LUTS. Patients were presented by moderate to severe LUTS, meaning IPSS score higher than 7, they had likelihood of 3-fold more complication. Not only LUTS, but again, the flow. If the flow is affected and it's weak, meaning like it is less than 12 in some guidelines, 10.8, the likelihood for those who have affected stream is 4 times to get complications. Again, and back to the MTOPS study. We came to know from the MTOPS study that the cutoff point of progression for the size of the prostate was 30-31. So patients who had larger prostate, larger than 31 cc, had more overall progression and symptomatic worsening, EUR, and invasive surgery. The mirror image, the proxy of the volume, is again the PSA. And again, from the MTOPS, PSA is higher than 1.5 or 1.6, the likelihood is higher when it comes to the progression, EUR and symptomatic progression and invasive surgery. This was reflected in the guidelines. There was a revolution in the management of PPH. Before 2010, the goal of the guidelines were mainly symptomatic, so alleviation of bothersome symptoms. But starting from 2010 and until this moment, there has been a change. So it is not only alleviation of symptoms, the bothersome symptoms, there is additional focus now on the alteration of disease progression and prevention of complications. And they went moreover, to what is called evidence-based practice. We all know about evidence-based medicine and the classification and the level of confidence when it comes to A, B, C, and D. But here they went to what we call individualized treatment. So every patient is different. If you consider the best evidence available, which is the evidence-based medicine and the clinical expertise, your esteemed clinical expertise, and one very important parameter which is neglected to some extent in our region, patient values. What are patients' expectations? How we can improve the adherence of the treatment? Patients can afford treatment in the form of cost or not, in the form of expected or listed side effects or not. If you consider the three, and we need to consider the three in one, we will reach to the personalized medical management or the evidence-based practice. To implement this theory, the European guidelines mentioned very clearly in 2014 the different treatment modularities versus how we can evaluate and make it suitable to our patients. First is watchful waiting, alpha blockers, muscarinic antagonists, and combinations. According to what? According to the speed of improvement, LUTS improvement or symptomatic improvement, the improvement of the flow, prostate size and disease progression, and whether or not there is a long evidence trials like longer than 1 year. And we can see here very clear, alpha blockers are doing very well and well established. Okay, they can do everything is good, except the size of prostate will not be affected, so prostate will keep increasing over years, and disease progression, it won't affect the long term, it will improve only the short term progression. And of course, many evidence when it comes to the duration. The second, as commonly used, is the tadalafil, or the only PDF5 inhibitor, which is already approved by FDA. And again, the gap is the improvement of the flow. They will not relax the urethra and will not affect the prostate size, and again, will not affect the disease progression. Last but not least, the 5-alpha reductase. 5-alpha reductase are very good, but it needs 3 to 6 months to get the maximum effect and improvement because it affects the size. So the logic came from the combination of alpha blockers and 5-alpha reductase. So with 5-alpha reductase, improve the size, decrease the progression, but again, in the first 3 to 6 months, adding alpha blockers will do the symptomatic improvement for those patients. And you might ask here why it is alpha blocker, because GSK was the first to invent the combination, and like 10 years back, when the research of Dudart, at that time, there was no FDA approval for the tadalafil at that time. Again, and back to the clinic, more than 3/4 of our patients have the risk factors of PPH progression with the prostate volume. So if we take 100 of our patients in the clinics, 75% would have larger prostate, larger than 30. Came from this study from Canada campus study and the big impact from Europe. So we do expect that 100 patients with the first diagnosis, at least 3/4 of them had larger prostate size. These are all over the world. It's almost, there's consensus all over the world when to use the combination. If we take the AUA, so lots with prostatic enlargement of volume like larger than 30 and moderate to severe lots. So now here we are in the dilemma. The dilemma is, with the first diagnosis, we have 3/4 of the patients indicated for the combination, being larger prostate, larger than 30 cc. But on the ground, and practically, you will see that mainly the management in the reality is more towards the symptoms, and it is not towards the root cause. We came to know, and this is not only a character in our region, no, it is different places all over the world. The Trovy study in France, the prescriptions of alpha blockers only without 5-alpha reductase is like half of the patients. And again, in Italy, It is like 2/3 of the patients were prescribed alpha blockers. And only a minority of cases was combination, like 20% or 17%. And interestingly, it is not only in Europe, it's again in Canada and America, it's the same. So there is a domination of alpha blockers on the reality, although the guidelines directing those patients towards on combination. So the question here, is there any evidence to support the practice which is dominated by the alpha blockers? The answer is there is evidence, but the evidence is different. The reality is something and the evidence is different. The evidence here, again, from the arm of doxazocin of MTOPS study. Doxazocin and placebo in EUR, which is in dotted line, and invasive surgery in the solid line. And doxazocin didn't show any statistical significance when it comes to the AUR and invasive surgery. And it's not only MTOPS, which was like more than 5 years. Again, the ALSIS study, which was already for 2 years, more than 1,500 patients, and again, alfazocin, placebo, there's no statistical significance for alfazocin here. Another retrospective analysis for more than 300 patients, and they compare the retreatment or the failure of treatment. Trazocin, like half of the patients in 3 years would have to change the medication. Alfazocin 37%, tamsulosin 27%. And those retreatment increases over time. So if the first 3 years they are 38, it will increase 2 years more to 54. But the challenge that we are facing in our region, that it's very difficult in the file of the patient to have one patient doing the follow-up for 3 to 5 years. That's why we are not seeing practically this retreatment or the failure of treatment. Another very interesting study. This is a retrospective analysis of more than 2,600 patients, and they compare between two things. First is to add 5-alpha reductase to the alpha blockers in the first 3 days of the initiation, and the second is to put it late or to prescribe the 5-alpha reductase in the 2nd or 3rd month. And they compare, this is the early, clinical progression in orange, then EUR in dark gray and light gray in surgery. Those patients were prescribed the combination early as 1st month. And these are the combinations where it's prescribed in 2nd or 3rd month. And you can see it's like 2-folds or 3-folds the clinical progression worsening of the symptoms, EUR and surgery. Again, this is a delayed, the gray and delayed cohort of the combination versus the early cohort. And you can see here, this is the patients with events or complications, and it is like double, the likelihood of having complication is double if there is delayed in the combination. One of the meta-analysis, which is evidence A, and comparing on the left side here, favoring the delayed combination, and on the right side favoring the early combination. And you can see it's far away from the midline, which is the cutoff point. And most of the studies, or all the studies, already statistically showing that they are favoring the combination early. To wrap up the first part and the take-home messages. First, alpha blockers monotherapy do not reduce the long-term risk and complication of EUR. Second, despite the evidence that I've shared with you, that the guidelines directing into the combination for patients who have 30 cc or PSA more than 1.5, still there is many patients who are indicated for the combination are only prescribed the alpha blockers, which is suboptimal. Last, current guidelines support individualized treatment. Every patient is different and no one size fits all. This is my first part. But the real question, I'm not here for only this. I'm here also to share with you if there is any newer evidence, because MTOPS study was like 2003, 14 years back. There is a very recent study published in the British journal Urology International 2015, and fortunately that the principal investigator was Klaus Royborn. I think Dr. Ashraf, he is one of the speakers in this conference from Texas. Dr. Royborn with his colleagues in US already conducting very interesting study. They had a protocol to compare efficacy and safety of fixed dose combination the first time to use DuDART as one single capsule versus tamsulosin, but it's not head-to-head, it's protocol to protocol. So they compare the DuDART from the start versus patients to be on conservative treatment, watchful waiting, then stepping up with tamsulosin. 2 years study, multi-center, randomized, open label because you know it is not head-to-head, it's a protocol or regime to regime. A parallel group, more than 700 patients. They are all treated naive. They didn't have any medication for PPH before. Older than 50, moderate size or moderate symptoms between 8 and 19 IPSS score, and the volume larger than 30, and PSA between 1.5 and 10. Here, I would like to ask the audience one question. If you have a patient for the first time you see in the clinic, and this patient is 50 years old, PSA is still higher than 1.5, let us say 2, and the size is like 30 to 40, how many of you will prescribe dutasteride, tamsulosin, in the whether it is separate capsules or single capsule? Please, if you go to use it from day one, just raise your hand, please. Again? Okay. If you have patient for the first time, didn't take any medication, first diagnosis of PPH, never take any medication, first seen in the clinic, he is 50 years old, PSA is still low, like 2, let us say, size of a prostate between 30 and 40. How many? And moderate symptoms. How many will prescribe from day one combination? Shall I take this one like?
The size between 30 and 40. Okay, so it's,
yeah, size between 30 and 40, PSA larger than, higher than 1.5, let us say take it like 2, moderate symptoms, and this is the first time for treatment. How many? 1? Okay, good. 2. Okay, this is study just to show the same example, because this is a practice. Many doctors prefer to start like stepwise, like watchful waiting, conservative treatment, adding symptomatic treatment, alpha blockers. Then, if there is worsening of symptoms, they're gonna add the eventually the 5-alpha reductase.
Yeah,
here,
but I don't think that it is wise to do it this way, isn't it? Because alpha blocker doesn't treat large glands. It relieves symptoms, but doesn't treat, isn't it?
yes, it doesn't treat as a root cause, but it decreases the symptoms, and the size is already 30, larger than 30.
Okay.
So it is still. But yes, I'm with you, Dr. Ashraf, 100%. This is study already done to answer the question: is it wise or not? So the first arm was fixed dose from day one for those patients, and the second is watchful waiting, what to do, what to drink, what to eat, and lifestyle advice with addition of tamsulosin if the symptoms didn't improve or worse. 2 years or 2 year study. Primary endpoint, the change in the IPSS or change in the symptoms, and the secondary time of the progression, and other secondary endpoint. This slide is for only the one arm which had the alpha blockers. So at zero, all patients didn't have any treatment. In the first 6 months, half of them were prescribed tamsulosin. The second 6 months, 58, then 60, then 61. So the message here is when the first 6 months there is worsening or of symptoms, and those patients were prescribed tamsulosin. And interestingly, in the first year, most of the patients were on tamsulosin, and really the difference in the 18 months and 2 years wasn't that much. So if there is progression of the disease, will be in the first year mainly. This is only one arm. So the message from this arm that those patients within 2 years will be progressed. Okay, back to the comparison. This is the primary endpoint, which is the IPSS score. This is the watchful waiting in light blue, and in maroon color, this is the fixed dose combination. And starting from those IPSS score was moderate, so they are between 8 and 19, so they were average 13. Over time, there is improvement in both arms, but the improvement in the combination arm was 7.6 versus 9.8. Interestingly, and here starting from the month number 9, there is lowering of symptoms below 8. And if it is below 8, it means that it became mild. Patients on combination after 9 months moved or improved one stage from moderate to mild. Progression, 29% of the patients progressed in the tamsulosin arm versus 18% on the combination, which is equivalent to 11% absolute risk reduction and 43 relative risk reduction. Meaning, if you have 10 patients on combination, you can save 40% of them in the first 2 years. The common question, and I will tell the answer before getting the question, the safety. How about the safety and adverse events? Here, erectile dysfunction was the main adverse event. It's like 8% versus 0. And retrograde ejaculation was similar, 5 and 4. And because, both arms had tamsulosin, so the retrograde ejaculation due to the alpha blockers are similar. So it is like 8%. For all the safety parameters, still what is known about the DUDART similar if you compare it to the COMBAT and you compare the combination in MTOPS study. There were no prostate cancer. Cardiovascular effects were similar, and there is no unexpected adverse events. And no fatal adverse events were with DUDART, although there was 3 serious adverse events with the tamsulosin arm. So to wrap up the CONDUCT study, which is published 2015, it already proved and support the first-line combination, whether it is 2 capsules or 1 capsule. Again, it's shown that there is rapid superior improvement and sustained for years. And it complements all what we know about the combination from MTOPS and COMBAT study. Last but not least, consistent safety, which is below 10%, whether it is retrograde ejaculation or ejaculatory dysfunction. To conclude my presentation, I would like to conclude by saying that PPH is a progressive disease. We have seen it, you know it. Second, clinical factors are there. Age, size larger than 30 or 40, PSA higher than 1.5, flow is less than 12 milliliter per second. The third one is patients are increased in the risk of progression. We can prevent them by early prescription of the combination. combination, and not because I'm GSK, but this is what the evidence tell us. They are the only medical treatment with the evidence of long-term, like 2 or 4 or even 6 years of the disease progression. With this in mind, I'm thanking you so much for your time and attention, and I'm very happy to get your reflection if you get questions that I can answer. Thank you.
Any questions?
I didn't say that at all. What I'm saying,
I didn't hear the question myself. What's the comment?
The doctor got from my presentation that there is no role for alpha blocker.
Alone in large prostates, according to most of the guidelines, and defining large is different from guideline to another. Some call it more than 30, some call it more than 40, and you should know that we are estimating these sizes from transabdominal ultrasound, which has plus or minus 30% variation from operator to operator. So if it is 30, it might be 20, or it might be 40. So actually, I depend on PSA more than a transabdominal ultrasound in determining which patients would receive the combination or not. So if it is more than 1.4 or more, they will get a combination. If it is less than 1.4, I will keep them on alpha blocker. No, the study was a combination versus watchful waiting with addition of alpha blocker starting the second visit if there is worsening of symptoms. So some of us see patients and they don't start them immediately on treatment. They wait till they have especially if there is no bothersome in the beginning, and these patients that have larger prostates are more at risk of having symptom progression and having their bothersome score to go higher with time. You are asking my opinion or the guidelines? In my opinion, I'll tell the patient that despite that you don't have symptoms, you are, according to the studies, you are at risk of future retention and surgery. I would tell him that what I would suggest for you is that you have frequent follow-up with PSA, and when he starts having symptoms, I would start him in combination treatment. The guideline says, the American guideline says, that you offer them 5-alpha reductase after discussing with them the pros and cons. In my opinion, in asymptomatic patients with larger prostate, the cons of having 5-alpha reductase is more than the pros, and however, I would leave that to the patient to decide.
Thank you, Dr. Ashraf. However, it's worth to mention that even the indication of DUDART is for symptomatic patients, moderate to severe. So even as online it will be off label to use DuDART or 5-alpha reductase if there is no symptoms. Yes, please.
Sorry?
Sorry, we didn't hear. Yes.
The combination? Okay. I think that the evidence is that you should continue the medication as long as the patient is having the benefit. The SMART study stopped the alpha blocker after 9 months, 6 months. And there is another study that stopped after 9 months. And 70% of the patients didn't notice a difference. So they were given a pill of alpha blocker and a pill of dutasteride. And after 6 months, half of these, they changed the pill of the alpha blocker with a placebo. And those that received the placebo, 70% of them didn't notice a difference. So it is safe, in my opinion, in patients that don't have a huge prostate, like over 80 or 100 gram, and they don't have severe symptoms, it is safe to stop the alpha blocker after 9 months. And if the patient have worsening of symptoms, it's just as easy of changing from Avodart to back to DuDART. Any more questions? Okay, thanks a lot. This was great presentation, and thanks for GSK for their continuous support.
Thank you.